Michael Stanton-Hicks was born in Australia, did a lot of his training in England, flew with the Royal Air Force, is still in his late 80s, a flying pilot, is an anesthesiologist, studied in the 1965, 67, 73, there was a guy named John Bonica, who was the founder of the International Association for the Study of Pain. He was up in Seattle. Michael mentions him in the talk, and I'll get to it in a minute. But Michael studied pain with him and then wound up being chair of the Department of Anesthesia at the University of Massachusetts in Worcester in the 80s. And then he was called to the Cleveland Clinic to start their pain program in the late 80s, and shortly thereafter I met him. But he had an interest in CRPS that started probably in the 70s, and he was involved in forming the International Association for the Study of Pain, which is the largest organization of pain researchers and clinicians in the world. And he started their CRPS group, and then in 1993, he brought together a group of experts from all kinds of different specialties from all over the world, all who had an interest in what was not yet called CRPS, to give it a name. And they gave it the name CRPS. And actually, Dr. Crane mentioned about that briefly. Well, he's organized over the years 2 meetings where we looked at how exactly to make a diagnosis, and 1 meeting to determine how we provide care called a treatment algorithm. And these are major contributions. And he was head of that group at the International Association for the Study of Pain, bringing in all kinds of people, identifying people who had interests in things related to this, so they'd all be there in one place to be able to do things. And his work makes him the giant. The other giant is Robert Schwartzman, who on another path at Drexel in Pennsylvania was working on CRPS feverishly as well. And both of them had really busy CRPS practices. Both of them retired. And I am kind of in some ways last man standing at a lot of the referrals of the horrible cases. I get to receive them and take care of them. So, Michael, I wish you were here. Michael, I cannot express more gratitude to you for how much help you gave me when I was starting out learning about CRPS when there really was no place to look. So he gave his disclosures. I don't think we need to do that. Okay, so he talks about this guy, Silas Weir Mitchell, again, the Civil War physician who first talked about it in 1864. And, you know, we're more than 150 years later, but I was in medical school 120 years later, and they never mentioned him. Then there was a guy named Lariche, and Sudeck, from where the name comes, Sudeck's atrophy. He was noticing how the bones got demineralized. They got thin, like somebody who had osteoporosis, except it's only osteoporosis in the distribution of your pain. So that was Sudeck's atrophy. And then he talks about John Bonica, who was born in Sicily, and his family migrated to the United States. He had no money, and he put himself through medical school as a wrestler, a professional wrestler. And I think he had the Masked Marvel. He trained in New York, so I guess he wrestled in like Madison Square Garden in New York. And then in 1944, he became head of anesthesiology up in Tacoma, Washington. And that's what he looked like. And I actually met him a few months before he died, just by coincidence. He sat next to me at a lecture. It's a kind of an honor. I have his 1965 textbook with really old pictures of it in it that I use at my own lectures. So here he brought together the group, and just if you want to know what he looks like, here he is. Right here, that's Michael Stanton-Hicks, and several of the people who are in this picture passed away, but 1993, it's 26 years ago. So there we had Michael in his early 60s, and now he's in his late 80s. So he starts, what do we know about CRPS? And somebody was telling me about the Beamer machine. Who is that? she stepped out. Okay, so dealing with the sympathetic vascular aspect. So we know fight, fright, and flight. In order to be able to get away from the tiger, we have to squeeze down on the blood vessels in the skin so that more blood is diverted to the muscles and you can run away from the tiger. And so that's a sympathetic tone, and what we see in CRPS is increased sympathetic tone, which is why the limb gets cold, because there's less flow to the blood vessels. We know there's inflammatory aspect. We see the swelling, their question of genetic aspects. The immune system, very interesting, ketamine, which we've talked about on and off over the course of the day, various people. Ketamine, everybody talks about the NMDA receptor, which is involved in the pain system, but one of the things we know about ketamine is there's something called tumor necrosis factor alpha, which is involved in the immune system, and turns out that ketamine also is a TNF alpha blocker. It's called a dirty drug because it has many properties, not just the NMDA property. The musculoskeletal aspects, we see the tremor. Somebody asked questions about the tremor. That's common in advanced cases. And then Dr. Crane was talking about the brain, and I talked about the brain in my talk earlier today. So there are the different things, the different tone over on the left at the bottom, the blood vessels, the inflammation, you see the swelling over here, and then abnormal sweating. Sweating's a sympathetically mediated thing too. Think about it, you get nervous, that's increased sympathetic tone, what do? You sweat. But sweating in just distribution of your pain is CRPS. That's not anxiety, although it can get worse when you have anxiety and CRPS. He has this thing here, nobody really knows how to treat it, so everybody's doing their different things. Hope this isn't stuck. There we go. Okay, so we've heard different things about physical therapy, and Michael, actually, in the treatment algorithm that was developed people came from all around the world to Malibu in 1995. Reactivation, contrast baths, desensitization, exposure therapy, then moving on to controlling the edema, flexibility, strengthening, correction of postural abnormalities. And these are secondary things that you do in physical therapy, not at the beginning. The beginning are the contrast baths and desensitization, and now things like what Dr. Crane was showing, which we're using also, which is the virtual reality, which is a form of desensitization. And then you get into special CRPS exercises and more range of motion. Then you get into aerobic conditioning, trying to maintain a normal posture, which a lot of people with CRPS get out of their normal posture, and doing multiple things. When you get into leaving the therapy, you want ergonomic evaluation of your work environment, more movement therapy, normalization of use, and really the end of a functional rehabilitation program, which is functional rehabilitation, getting your function back, being able to go buy the groceries, and being able to wash your dishes and make your kid's bed, or make your kid make their bed. I'm a dad, I know about that. So along the way, you can use medications or blocks, and psychotherapy is very important. He's kind of outlining what we put together in 1995. My doctor told me to start my exercise program very gradually. Today I drove past a store that sells sweatpants. So you want to treat the symptoms, so you want to treat the pain, but the goal is, and here again, he puts a red arrow, not in isolation, talking about it. I think Dr. Sadiq talked about it, Dr. Crane talked about it, I talked about it, and the message that all of you have to take home is use it or lose it. Even if it hurts, push through. And I'm not telling you to be some tough giant, I'm just telling you to do your best to use your limb and don't baby it too much, because it will get worse if it, I see patients come in, they initially come in and they have nothing on. Then they put a glove on, then they're wrapping it all around. You know, patients have seen 6 doctors. They come in like with a tent. I had a guy come in like with a tent the other day. And he had, well, he felt strong smell, so he had things in his nose, and he had cotton in his ears. And he was like, somebody was asking about sensory deprivation. Well, this guy was doing about his, and black sunglasses. So this guy was about as close to sensory deprivation as you could be, and it clearly wasn't helping him. There are different medications, and this is something that is as much an art as it is a science. I mean, the science is knowing what the medicines do, and the art is finding the right drug for the right patient with the right side effect profile. You don't want to gain weight, there are ones that have you lose weight. A lot of these drugs make you gain weight. You're really tired, maybe you should use one that has a side effect of being energizing. So you have to know a lot about your pharmacology. And then he makes the point that there's a difference between warm and cold CRPS, and all I could say on that is amen. Warm CRPS is an earlier phase, and cold CRPS is a later phase. When I get somebody who's had it for a while and they're still warm, you have much greater chance of getting to 100%. It's usually easier to treat them in general. When it gets to be cold, you're already having to turn more stuff around. And we see patients that they start out warm, they get cold, and then for whatever reason they start being warm, and you say, hallelujah, let's work now while you're warm because we have a better chance. You got to manage the pain along the way. Dr. Crane indicated how he's not a fan of opiates, and I would agree with him in general. However, I do prescribe short-acting opiates to my patients so they can go do physical therapy, because you got to do the physical therapy, and if it hurts, you don't want to do the physical therapy. If you can give some medications to allow you to do the physical therapy, then that's good use of opiates, and that's what opiates are there for. Okay, so he just talks about the different kinds of treatments. One of the things that really has to be understood is that there are different kinds of CRPS, and although there's type 1 and type 2, that's not what I'm talking about. There can be the type that's predominant, the predominant feature is the pain, the allodynia, where you can't touch it. And then there are kinds where the predominant feature is the swelling, like the brawny edema. And then there are ones where the movement disorder that lady who was standing over there asking questions was talking about the predominant movement disorder. And when you have them all put together at the same time, we call it florid. But based on how it presents, we treat differently, and that's important. And that, again, is where it's really worth going to somebody who has experience. It's just like Eskimos have like 30 words for snow. I was just skiing this past winter, and the ski instructor was telling me all these words he had for snow that were all related to the name of food. Whatever. The thing is, they see snow all day long. They name it differently because they can see the differences. And if you are a CRPS specialist and you are having 20, 30, 40 new patients a month coming in your office, you're going to see the differentiation different than if you have 12 a year at most, or 4 a year. And so that's where experience gives you really good judgment on what to do. And a friend of mine who is a spine surgeon, he basically said, experience gives you good judgment, and bad judgment gives you lots of experience. And so you learn kind of what to do and what not to do over time. So his main role in this lecture was to talk about neuromodulation, and I'll just break it down. I was president of the North American Neuromodulation Society, so aside from CRPS, that's another passion of mine, implantable devices that control both pain and movement disorders. And there's a big overlap between that and CRPS and the kind of population of CRPS patients that I have that need neuromodulation in order to get their CRPS pain under control. So what is neuromodulation? Nerve modulation, changing the nerves. And there are various ways to do it that his slides will now present. But it mainly derives from pacemaker technology, sending electricity to the nervous system, very similar to a pacemaker. I think there are 3 companies out there with displays. So what is neuromodulation? I just went, a technology or science that can modulate central peripheral nerve activity by electrical or chemical means. So there's spinal cord stimulation, where you put a lead in the epidural space and you send signals to the spinal cord. There are different frequencies that are now available. There's dorsal root ganglion stimulation, which is where you get the nerve as it's coming out of the spine. And there's peripheral nerve stimulation, where you lay the lead right over the nerve, usually through a needle, under ultrasound, right over a nerve. And then one that has been a big part of my career is delivering minute amounts of medicine directly into the spinal fluid, or yours is actually on a peripheral nerve though, right?
She does both the dorsal and the intrathecal.
Oh, it is an intrathecal.
Yeah,
It's
I love the intrathecal pain.
okay. We have somebody who has a perfecta here, both a pump and a stimulator. So the pump delivers minute amounts of medication right into the nervous system at much lower doses than if you were taking them orally to accomplish the pain relief without the side effects of taking the large amounts of medication, and it can be incredibly gratifying when it works. Now, the thing about both stimulators and trials is you never do the permanent one until you do the trial. And so that's really neat in modern medicine, because if you have back surgery and you decided you really didn't want that back surgery, it's done. But if you want to try a stimulator, see if you like it, and you try it and you like it, you have one put in. If not, you take the wire out and you're no different than you were. So you didn't commit to anything. Fully reversible, non-destructive. Even if you put it in permanently, it's not really permanent. You can always take it out. And that's what we hope for. Happens between 5 and 20% of my patients don't need it anymore, and we're very happy when that happens. There's also deep brain stimulation, which gets to what Dr. Crane was talking about, the focus is in the brain where the pain is processes, that you can actually make a tiny burr hole. This is not something I do. Tiny burr hole in the head, and under what's called stereoscopic vision, actually put the lead right to where pain gets processed, and a tiny amount of electricity blocks out the pain signal. And that is truly, truly the last resort when nothing else is left. But it does work. Okay, so he has this fancy diagram. Spinal cord stimulation in the epidural space at the cord, or in the neck to do the same thing. Dorsal root ganglion stimulation, where the nervous information is right coming from the periphery into the nervous system. Peripheral nerve stimulation, where the lead is placed over the nerve, various parts of the body. And deep brain stimulation, well, you get what that is. Okay. Oh, and then there's intrathecal drug delivery, and that's where you put the tiny catheter. It's a really fine catheter that delivers minute amounts of medicine into the spinal fluid. I'll just say, historically, I started out my career, it was 90% pump because stimulation had not evolved. But I did my first stimulator in '93, which is 26 years ago. And if you think about what a cell phone looked like in '93 and what a cell phone looks like and does now, you see the difference. And in '93, you could talk on an analog phone. My phone, I carried in a briefcase. It was before the brick. I mean, I actually had a briefcase. It was like 20 pounds. And all I could do was talk on it. And now you know what a phone does. You can watch movies on it. It has a camera in it. You can listen to Spotify. I mean, you can do everything on your phone. Has a directory, a calendar. I don't have to go into it. You know how different it is. Well, the stimulators have advanced the same way, and the ones that I used to put in were like little bricks, and now if you look at the people who have their demonstrations out there, they're really small. And I used to be able to program 4 contacts, 1 program, and it wasn't rechargeable. So 4 contacts, 1 program, that's all you had. Now there are manufacturers that make 32 contacts with as many programs as you could ever conceptualize, like essentially an infinite number of programs with all kinds of different waveforms that do all kinds of different things. And It's rechargeable, so you don't have to worry about managing the battery if you give higher output. So 90% pump, 1992, 93, 90% stimulation, 2019. Because stimulators are so much better than they were, I don't use pumps as much, but I use pumps when I need to, and they're really, when you need a pump, it's a great thing to have. And for cancer pain, there's truly nothing like it. And that was what it got its first FDA approval for. So he talks about the choices, and you know, I think we're running late, and this isn't my lecture. What I will just do is editorialize a little bit here. So he's talking about, you know, the severity of the different pain problems and how you choose what to use. And so when you have CRPS involving multiple limbs, all the systems can do 2 limbs, but if you are unfortunate enough to have 4-limb CRPS, there's now a system where you can have 1 lead for each limb. The good news about that is you can put it all in one system. The bad news about it is that something that has come along in the last 5 years that didn't exist is MRI compatibility. So MRI compatible 2-lead system, MRI compatible not 4-lead system. So if you want 4 leads at one time, you either put in 2 stimulators or you put in a 4-lead non-MRI compatibility. Now, there was a time where nobody thought MRI compatibility was that important. Now, I wouldn't put a system in if it's not MRI compatible, because who knows, 10 years from now, if you want an MRI, you don't want to have to take out your system to get your MRI. So MRI compatibility is important, and that's something that's also changed. Now this, to me, has a little bit of an advertising flavor to it, so we're going to stay away from it. It's not my lecture, I don't do that. Pain specialist with CRPS experience. Again, spinal cord stimulation is not the first thing you want to do. You want to try physical therapy, you want to try nerve blocks, you want to try medications, you want to try it all put together, and if it doesn't work, if I do a lumbar sympathetic block, which is a block for the leg, and it works and it lasts 2 days, I'll do another one and see if it lasts 4 days or 3 days. If it doesn't last any longer, there's no point, and we all know that saying, the definition of insanity is trying to do the same thing over and over again and hope you get a different result. I mean, in Japan, they will do up to 600 nerve blocks to sustain these people, doing them day after day, but they don't last any longer. To me, that's unnecessary torture. And a stimulator, that's when you do a stimulator, where you have a block that works, so a stimulator likely is going to work, but the block doesn't last, it's time to do a stimulator. And we have new kinds of stimulators where you don't even feel the stimulation, which we didn't have even 5 years ago. You don't feel the stimulation, so you just turn it on and you're good. So you want somebody that, Michael is saying, that has experience, and again, you want somebody that doesn't do just one modality. Because if they do one modality, that's what they're probably... I gave you some sayings. I have lots of sayings. One of my sayings, if you don't know what to do, you do what you know how to do, even if it's not the right thing. And unfortunately, we see that among some physicians. So it's nice to have a lot of different things that you can do, so that one of them will be the right thing. And so that takes me to another one of my sayings, which is, and this is, I think, one of the most important: the right procedure for the right patient at the right time. Skip one of those. It may not be the right time. The patient may be too depressed to get benefit from it. Maybe you want to treat the depression a little bit first before you even consider doing the stimulator. And that's why all the patients get a behavioral evaluation before you proceed to a permanent implant. This one's kind of cute. So here you are in a tough situation. You have the flying doctor, and then you have the flying second opinion. I think that caters to his flying interest. So I can go on. I mean, well, this is a very important point he makes, and that neuromodulation systems, whether it be stimulator, spinal cord stimulator, peripheral nerve stimulator, dorsal ganglion stimulator, intrathecal pump, they serve one purpose, And that's to be able to get you off your ass, to be able to get you into functional rehabilitation and not have to be encumbered by the pain when you're getting better. Because in order to stay better, you have to start moving, use it or lose it. And so, as somebody who truly believes in neuromodulation, I contract with my patients at this point, I didn't used to, that if they want me to put in a system, they have to commit to 4 weeks of what some of my patients affectionately call RSD boot camp. I thought you called it. No, Sherry, you didn't call it that? No. Some of my patients call it RSD boot camp because we basically kick your butt. But you get better, and so it's worth it. But to me, there's very little point with what I know now, even different than what I knew 15 years ago, putting in a stimulator unless you're going to commit to really trying to get yourself better. So, while they make someone walk again, they should be considered aids to physical, occupational, and physical therapy. And that's the bottom line. Michael has a lot more slides, but it's getting late in the afternoon. I don't think they really say that much more. The main point is to raise the awareness that neuromodulation is around, that in the audience I know of several patients in front of me that have had neuromodulation change their lives. That for me, one of the things that I've said over time is that if I didn't have certain tools like neuromodulation, I probably wouldn't continue to be practicing in CRPS, because the patients where I would get stuck, neuromodulation often allows me to get past it. Again, it shouldn't come at the beginning. It's a useful tool, and it's a tool in conjunction with everything else. But it really makes a difference. The technology's advanced incredibly, and it's something I truly believe in. And so with that, we should thank Michael Stanton-Hicks for putting this lecture together and me for having the privilege of giving it, and to thank him or to congratulate him in his absence for his award. Thank you.